I've been using the digital AcuBlade probably about a year and a half. Now, the evolution of the analog AcuBlade to the digital AcuBlade was fantastic. The first time, I remember distinctly the first time I used it in the operating room, and you know, I felt like I wanted to get up and go eureka, because it just, it was it was wonderful. I guess that would be the best way to say it, that it was logical, and in terms of the evolution of small spot sizes and then scanning devices to deliver laser energy, carbon dioxide specific laser energy to the human larynx, where precision is so critical, that this was just the next step and the quantum jump from, you know, sort of tolerating an analog device to now having a device that finally was surgeon friendly, user friendly. And so what we get then, you know, in terms of advantages, well, obviously the number one advantage is precision. Now, to me, the number two advantage is a reproducible laser tissue interaction that will give us then an ability to achieve expected outcomes with our patients. So in a world of evidence-based medicine, when we start talking now of being able to deliver expected laser tissue interactions of a certain length, a certain width, and a certain depth, and minimal collateral damage, deep as well as laterally, we're talking then about being able to take these outcomes and moving them from Vanderbilt to any other place in the country, as long as the person utilizing that laser has had an opportunity to learn how to utilize this digital AcuBlade and what type of an approach they want to make to achieve certain outcomes based upon the pathology that they face. I've found it easier to teach with, to both my fellows as well as residents, because a lot of the question marks, a lot of that, you know, unknown, such as how deep am I going to go now, are controlled so well with this scanning delivery. So in terms of minimization of deep and lateral thermal damage, you know, the scanning delivery of the laser beam is really the key there, and how the laser is set up at the console by the nurse or the laser nurse or the surgical assistant or whomever it is that is pushing buttons and setting things up. But by telling the laser what size and what kind of a beam you want delivered, that helps to minimize the lateral and deep damage. Because in so doing that, you are, you know, telling the laser, or you are programming into the laser the depth of penetration and the size of the spot that will be scanned. So it's a great laser then to do photoablative work for recurrent respiratory papillomatosis, especially as you get close to the human vocal fold, and or treating superficial spreading variety of papillomatosis, where, you know, scanning that papilloma as it spreads out on the vocal fold, the ventricle, the false vocal fold, or the subglottis, allows you to literally photoablate layer by layer by layer. And it's just exquisitely precise. If you want to work in bilateral true vocal fold immobility and want to perform a posterior transverse chordotomy or an endoscopic laser retinoidectomy, once again, you can make your cuts in the chordotomy operation from medial to lateral with a straight line, and make your cuts just anterior to the vocal process, and see the exquisite precision associated with those cuts as you work from the surface of the vocal fold inferiorly to be able to cut the anatomical tendon or attachment, the ligamentous attachment of the vocal fold to the vocal process. And as you photoablate in the endoscopic retinoidectomy, you have the exquisite precision to see yourself photoablating mucosa coming to the mucoperichondrium junction, and then photoablating, you know, your mucoperichondrium and your perichondrium flat or level, and then working next to denude further mucoperichondrium from the underlying arytenoid, and then photoablating that arytenoid working from the top to the bottom in the stepwise fashion that that operation is performed. Even in the face that no two papillomas are the same, no two posterior transverse chordotomies or endoscopic or retinoidectomies are the same, nor are any vascular lesions the same. But given the pathological types, my ability to, reproduce my previous good results are afforded me by that digital AcuBlade more so than any other previous delivery system. And through that, I feel that I can then teach residents and fellows these same techniques in this same reproducibility with the same precision, laser tissue interaction that's predictable, and ultimately, the ability then to reproduce best practices and have your or their results fall within the same realm as mine in terms of being able to achieve that best practice and ultimately then being able to gather the data, so that we can have evidence-based medicine. So am I excited about the introduction of the digital AcuBlade? Absolutely yes. Do I find it helpful to me as a laryngologist? Absolutely yes. Do I find it helpful in terms of training the future generation of otolaryngologists and perhaps as well as laryngologists because of the fellowship training? Absolutely yes. Is there an opportunity for somebody to come out with an improved bell or whistle, in the form of Generation 2 digital AcuBlade or Generation 3? Well, I'm sure there is, because I don't think anybody wants to rest on laurels. I am sure that engineers, physicists, marketing people, and surgeons alike are all looking forward to say, hey, this is great, but. And it's that but that keeps the minds churning to come up with something that's even better than that which we have now. And I look forward to that. And I look forward to continuing to practice and hopefully having it in my hands, because it will be spectacular based upon how good of a tool and how helpful the digital AcuBlade has been in the year and a half that I've had the opportunity to utilize it.